Good
So I
evening,
have to
everyone.
start this.
Oh, Good evening, everyone. This is Catherine Mickelson at NATF in Boston. Thank you so much for joining us this evening. We are joined by our moderator tonight, Dr. Sam Berkman, who is joining us from UCLA, where he is a clinical professor of medicine in the Division of Hematology Oncology. He's a graduate of Tufts Medical School and completed his hematology fellowship at UCLA and medical oncology training at the NIH. He has consulted on thrombosis cases at UCLA and Cedars-Sinai since 1985, and he's been recognized 6 consecutive years as the outstanding teacher in the UCLA Department of Medicine by the medical health staff. He's also published many articles about thrombosis and is a regular contributor to the McMaster University Evidence-Based Newsletter. So we are very pleased that Dr. Berkman was able to join us this evening. And I will pass the controls over to him so he can go ahead and get started. Dr. Berkman?
Thank you, Catherine. So it's an honor to be asked to be a speaker for this very prestigious organization. I've looked at your list of previous speakers, and they're very, very impressive. So I'm hoping to just see if I can fill these big shoes. So basically, I'm going to talk to you about bleeding. And my first slide is up here. The order of the talk is I'm going to talk to you first about the different anticoagulants. What is bleeding? First of all, what's major bleeding, what's minor bleeding, what's nuisance bleeding, and what's new in bleeding. So I am going to assume that you're not physicians, but because you have an interest in thrombosis, you know more than the average person, and you know terms like Xarelto or Eliquis. I'm probably going to use brand names because they're probably more familiar to you, not to try to give any type of marketing. Just because I think they'll probably be more familiar. So basically, let's just talk for a second about the various anticoagulants. Anytime someone gives you an anticoagulant, it's because they're concerned that you could have a life-threatening blood clot, like an embolism from atrial fibrillation or a pulmonary embolism from a deep venous thrombosis. No one gives these drugs out lightly. They give them out because they're concerned about a worse event happening. So that's the reason you get these. And if you're getting Coumadin, you're going to get checked every 3 weeks. If you're getting the new anticoagulants, Xarelto, Eliquis, Pradaxa, you don't need to get checked every 2 weeks, but your doctor's going to want to know if you're bleeding. So if someone calls you up with your results from your test, if you're taking Coumadin, or if someone, you just go in there every 6-8 weeks with your Xarelto or your Eliquis and ask you if you're bleeding. If you've had nosebleeds, if you've had bruising, you can tell them you're bleeding. But the point I want to make here is that the most serious bleeding that you could have is not something that may be recognizable to you as bleeding, and that is a headache. A headache is the most serious type of bleeding you could have because it can be the sign of bleeding in the brain. And people may not ask you that. They may not ask you, do you have a headache? They may just ask you if you're bleeding. So if you have a headache on anticoagulants, and it's not a typical headache you have, or even if it's like a typical headache you have, but not exactly like it, you want to tell them that. Because some doctors may not call you themselves, they may have some assistant call you, and they may not know enough to ask you that question. Okay, so this picture here is of a pasture. And unfractionated heparin is the first anticoagulant I want to talk to you about, and that's kind of been put out to pasture pretty much for deep venous thrombosis. Pulmonary embolism used to be that 15, 20 years ago, you got a deep venous thrombosis in the leg, you're in the hospital for a week getting infusions of heparin, and then transition to Coumadin. And heparin has the advantage that it's got a very nice reversal agent, can be reversed immediately. But today, in today's world, the only real heparin you're going to see probably is if you have a coronary artery event and someone's going to put a stent into you, they'll probably give some heparin bolus so that you don't clog off the stent when they put in the equipment, the catheters and etc., and the tubes. So basically, this was the first drug that was used. And the other reason you might get heparin is if you've got a lot of pain in your leg, doctor may put you in the hospital for a blood clot in the leg because you're in so much pain, give you heparin because it's got an anti-inflammatory action. But this has been replaced by and large over the last 20 years or so with low molecular heparin. And the problem with that is that it hurts. It's an injection and it hurts. If you get it twice a day, it hurts twice a day. But the good news about it is that you don't need to be in the hospital for that. So when this got introduced around 2000, a little earlier, people could be sent home from the emergency room rather than be in the hospital for a week. And that was a big paradigm shift. Now today it's mainly used for cancer patients based on a study in 2003 that showed it was better for cancer patients with clots than Coumadin. But most recently, these new oral anticoagulants have been shown probably to be just as good as low molecular heparin. Now, Coumadin has been the mainstay of treatment for atrial fibrillation, deep venous thrombosis, heart valves for several decades. And Coumadin is like a great basketball player. In other words, it's like a player who's like in the top 10 every year in scoring, performs very well. Well, why replace it? Why bring in these new drugs if it performs so well? Well, because it's like a great basketball player who's temperamental and doesn't get along with his teammates, or he's late for practice, or he fights with the coach, etc. It's all these limitations with it, like it takes 4 or 5 days to work. There's multiple food and drug interactions. You have to keep the green vegetables constant in your diet. It requires frequent monitoring. You have to go in every 3 weeks or so. And it's the most frequent medication associated with the hospital emergency room admissions. So people decided that even though it behaved it was a very good performer, all these other things, they decided to compare it to the new oral anticoagulants to show that the new oral anticoagulants were just as good. They didn't think they'd be better, but they thought they might be non-inferior, which means just as good, and not have all these other problems you see listed on the slide. But what was found out, interestingly enough, that in addition to the decrease in cerebral hemorrhage, which we see in the new oral anticoagulants versus Coumadin, basically 50% decrease, that if you look at this slide, you'll see that these different trials here, like Rocket, if a person has a bleed on warfarin, a major bleed, they have a 14% chance of dying versus 7 on Xarelto, or 13% risk of dying on Coumadin, warfarin, versus 9 on Pradaxa, or 12% versus 10% on Eliquis. So you can see that not only are these new drugs non-inferior and work just as well to prevent clotting and embolization, but they're safer, because if you get a major bleed, you're less likely to die on them. So what are these new drugs anyways? Well, you see them listed here, but some of these names may be a little bit foreign to you, but you may be more familiar with the brand names, like dabigatran is Pradaxa, rivaroxaban here is Xarelto, apixaban is Eliquis, edoxaban Cyvasa, and betrixaban is Bevesa. And if you have a deep venous thrombosis or pulmonary embolism, chances are your doctor's going to put you on Xarelto or Eliquis, because these drugs do not require you to get 5 or 6 days of intramuscular injections prior to it. So you're probably going to get one of these 2 drugs. And none of these drugs have been compared with each other head to head. So any claims that pharmaceutical companies make, for example, Xarelto, that it's once a day, so it's better, or that Eliquis makes that it's twice a day, so it's safer. These claims are really not based on any kind of science. I think you should ask the doctor why he gave you Eliquis and why he gave you Xarelto, but basically they've never been compared with one another. So let me go back here. So the people who claim that, for example, Eliquis is safer, they say, well, twice a day you have lower peak levels In other words, here's the green, the once-a-day drug. You see the peak level goes much higher and the trough level goes much lower, whereas with the twice-a-day drug, the peak level is lower. So they say that this drug's safer because you have a lower peak level. Well, that makes sense theoretically, but the fact is that in trials, this looks just at trough levels. It shows that the probability of a major bleed is related to the trough level and not the peak level. And the probability of a stroke is also related to the trough level. So these arguments between the drug companies really should not influence you. Now, basically, so then why haven't people switched more to the new oral anticoagulants, given that they're safer, etc.? Well, because until recently, there were no reversal agents for these drugs, and people were concerned about them, that they couldn't be reversed. But the fact is, and like doctors also, like the oral surgeon who would pull a tooth with impunity, with the person fully anticoagulated, wouldn't go near it with one of the new anticoagulants. But the fact is that these drugs are safer, whether they had a reversal agent or not. Many of the older drugs we use, like argatroban, fondaparinux drugs, they have no reversal agent, and low molecular weight heparin that I just mentioned has no reversal agent. We've used that for years. Heparin has got a great antidote, but it's been put out to pasture in deep venous thrombosis. And even when we reverse Coumadin, if a person's got a major bleed, it doesn't correlate with safety. And the need for reversal is really not that common. So for a long time, and influenced by attorneys, late-night attorneys who get on television and start frightening people about reversal. But now the reversal agents are here, so we have them. And basically, who should we be using them on? Well, we should use them on people with major bleeding. So what's the difference between nuisance bleeding, minor bleeding, otherwise known as clinically relevant non-major bleeding, and major bleeding? So nuisance bleeding is bleeding where you don't stop the anticoagulants, like bruising, maybe hemorrhoidal bleeding. A doctor will just tell you don't worry about it. Minor bleeding is bleeding. It's not minor to the patient and it's not minor to the doctor, but everything's relative. It's not life-threatening. Maybe a nosebleed, maybe a one-unit gastrointestinal bleed, maybe a urinary bleed. And major bleeding is life or limb-threatening bleeding, and that's where you want to consider using the new reversal agents, and that's the what's new part of this talk. So what is major bleeding anyway? So major bleeding is bleeding into a limb, where you could end up losing a limb, bleeding into a critical organ like the brain or the heart or an eye, or bleeding where your blood pressure is unstable, like with unstable vital signs, or bleeding into the chest cavity or the abdominal cavity, which is closed, or a person who has a significant drop in their blood count. So all of these would be signs of major bleeding. Now, that doesn't mean, however, that every case of major bleeding necessarily needs a reversal agent. There's a lot of measures available to us that are sufficient to stop major bleeding. Like stopping the anticoagulants, the first thing to do. If it's a trauma patient, you may want to just compress them and stop the bleeding. Excuse me. Now, if it's a GI bleed, you may want to have a gastroenterologist see the patient, stick a scope down there, and clip the vessel, and give them volume, which is like saline, or blood products like a transfusion. And the majority of major bleeds can really be handled this way. So, but they should be considered for reversal if these things don't work or more severe, or particularly if it's a bleeding into the brain, they should definitely be considered for reversal. So what are the reversal agents available? Well, there's some specific agents, and I'll get into these. One is called idarucizumab. It's also called Praxbind. And the other is called Andexanet alpha, just approved this year, May 5th, and that's called Anexa. And then there's agents that are not specific, but have been used because they're the best we have. And these are called four-factor PCC, and I'm going to show you pictures of these drugs so you'll see them. Because that's what we use for reversal when we need to reverse somebody, which is usually going to be someone with either a bleed in the brain or a major GI bleed where they get bleed out several units of blood, at least 2, and their blood pressure is not stable, and their heart rate's going too fast, etc. But you want to go, if you can, with a specific legislation that's available. It's just that they're not available at every hospital, so you may have no choice but to use these below here, the non-specific ones. And they're under tight control by pharmacy and administration, etc. They're very costly. So this slide tells us which products we use for reversal. So basically, if you have a bleed on Coumadin, you use this drug called K-Centro, which is 4-factor PCC. So let me explain this to you exactly why you use this. What this product is factor 2, 7, 9, and 10. Well, what are those factors? Well, this is the clotting cascade here. This is a single reason, this cascade, this slide, why people who go into internal medicine steer clear of hematology. They find it very confusing, and I'm not going to explain it. I'm just going to show you the different factors. I'm going to point them out to you. They're all factors that join in to form a clot. This is factor 2 right here. This is factor 7 up here. This is factor 9 and 10. Now, these are all factors that when you give a person Coumadin, what happens is they stop making these factors. But what happens is the levels of the factors that are there does nothing to them, so it takes about 4 days for them to drop off. Your 10, your 9, your 2, and your 7. So therefore, when you give these people 4-factor PCC, you're basically giving them what they don't have, and it works real well for them. But if you're giving it to someone who is being treated with a drug like Xarelto or Eliquis, what that drug does, it does nothing to factor 2, it does nothing to factor 7, it does nothing to factor 9, it just does something to factor 10. So by giving them this product, you're giving them 2, 7, 9, which they need like a hole in the head. They got plenty of it. And the 10 you give them is what they need, but the problem is they've got an inhibitor, an antibody, which is going to basically, or it's really a decoy molecule, it's just going to prevent it from working. So this is kind of like a blunt instrument when you're using it for rivaroxaban or apixaban. So the reason for that is that it's better to use Andexanet if you have it, because that's more specific to these drugs, and I'll show you the mechanism of action. So you use Andexanet for Xarelto and Eliquis. You use Coumadin, K-Centro for Coumadin, and you use Praxbind for Pradaxa. You can't use Praxbind for Xarelto and Eliquis, and you can't use Andexa for Coumadin or Pradaxa. So these are each basically, you should stick to it, but you can use K-Centro. So let me go over that again. You cannot use Andexanet for Praxbind. You cannot use Praxbind for these, but you can use K-Centro for these, but you're much better off using this if you can. So basically, now let's talk about Praxbind. So how does Praxbind work? Well, here's dabigatran, Pradaxa. It's a little teeny thing. And here's thrombin. The way it works is it binds to thrombin and prevents thrombin from, it inhibits it. But when you put in idarucizumab, you see how much bigger idarucizumab is. It just yanks the Pradaxa, the Praxbind, the dabigatran right out of the jaws of thrombin. I'll give you a good metaphor. If you look at dabigatran as the healthcare dollar here, and you look at thrombin as doctors and hospitals, idarucizumab is like the insurance companies. It comes along and just grabs the healthcare dollar right out of the mouth of the poor, starving, hungry doctors and hospitals. And that's how it works. It's an antibody, and it's very, very avid, 365 times more avid. And it only works for dabigatran. And a study showed in 500 patients, 300 bleeding patients and 200 surgery patients, that the drug reversed the bleeding parameters immediately, within minutes. Bleeding stopped within a couple of hours. The surgery patients could start their procedures very quickly, and they had very good stopping of blood. There were some blood clots, but not too many, and most of them occurred remotely from giving the drug. But clotting events do happen in people who are predisposed to clot to begin with, and you have to stop their anticoagulation. Not only that, but give a reversal agent. Has to do with the population, and they have a high mortality rate because cerebral bleeding in the brain normally has a mortality rate of like 45, 50%. And they were able to restart anticoagulation in the majority of patients in a mean of 13 days. So if you have trouble remembering the name idarucizumab, pretend you have an imaginary friend named Sizumab, and you challenge him to a sword fight. And you say, I dare you, Sizumab. That's how you can remember the name, idarucizumab. Or you can just call it Praxbind. Now, the new drug that I want to talk about and emphasize in the last part of this talk has to do with andexanet, which we mentioned earlier, which binds to rivaroxaban, apixaban, edoxaban. This is Xarelto, Eliquis, Tyvaso, and enoxaparin. Now, the blue is Xarelto or Eliquis, so it just binds to it. And here you have regular factor 10A, which I showed you before. It's an important clotting factor. And here you have andexanet in the middle. And andexanet acts like a masquerader or a decoy. It kind of binds to this, and in doing so, it frees up 10A to form clot, which is what you want in a bleeding patient. So it's not an antibody. It's just a decoy molecule. And so that's the mechanism of action of how it works. Now, studies were done on healthy volunteers. These were people between the age of 50 and 70, average age 58. They received 3 to 4 days of andexanet, regular dose, at 20 milligrams a day, rivaroxaban, and 3 hours later, they got andexanet. So as they got a steady state after 3 to 4 days of these anticoagulants, and then corresponding to a peak level, they decided to reverse them. And they gave one group placebo, and they gave the other group the andexanet. And basically, they wanted to see how well it reversed the anticoagulant. So basically, this slide is kind of complicated. I don't expect you to understand it. I just want you to look at the red line here. So this is the level of Xarelto prior to giving the andexanet, and you can see how it free fall plummets all the way down to here when you give the drug, as opposed to placebo, it hardly moves. Now, if you don't follow the injection with an infusion, it comes up pretty quickly over the next few hours. But if you give an infusion, it will stay down. And basically, the drug should be given as an infusion over 15 minutes and then a 2-hour infusion, bolus and then an infusion. And that's how the drug works. And this is the basis on which it was approved by the FDA on May 5th of this year, is on this slide here showing just how effective and how much it plummets the level of the anticoagulant. And that's all you really have to understand about this slide. Now, even though you're basically taking a person who's on anticoagulants for 3.5 days and you're just stopping them abruptly, and you give them a reversal agent, it elevates certain parameters, that certain tests that would show increased clotting. Nonetheless, none of these healthy volunteers, despite the fact that the anticoagulation stopped, that they got the reversal agent, that they got increased thrombin, which is a clotting factor generation, none of them got a blood clot, implying that this drug does not cause clots in people who are not otherwise predisposed to getting clots. But, excuse me, I went backwards. Now let's look, however, at patients who are predisposed to developing clots, bleeding patients. So these are patients who have major bleeding on andexanet and rivaroxaban, on apixaban, rivaroxaban, Eliquis, and Xarelto. And they had they got this drug, Anixa, within 18 hours of their last dose of Eliquis or Xarelto. About 60% of them were bleeding in the brain and 35% on that GI bleeding. And what it showed was that 83% of them had an excellent or good result. And it didn't matter whether they were getting Eliquis, Xarelto, Cyvasa, whether they're a man or a woman, the site of the bleed, the age, it didn't matter. They basically all responded similarly, 83%. So that's pretty good. However, you don't know how people would have responded by just stopping the anticoagulant, because it was a one-arm trial. It was felt that it would not be ethically right to put people in a placebo group where they're having life-threatening bleeds. And there were side effects. Basically, there were 12% mortality in the group, which is what you would expect, people having cerebral bleeding. And there was 11% of them had blood clots by 30 days. We don't know how much of that has to do with just stopping the anticoagulants or giving reversal agent. But they were restarted basically the anticoagulant was started in 157 patients, and 57 patients by 30 days. So in summary, reversal agents are very effective and rapid in reversing direct oral anticoagulants. They work very quickly. They're a group of people with high underlying mortality because of the fact that they got to be on anticoagulants to begin with. There were no thrombotic, no clots or serious allergic reactions in healthy volunteers. Most clots in the clinical trials occur remotely from the time of reversal. And because there's no control group, we still don't know, and we won't know until the results are completely released about all of the results in the trial. But the FDA has approved this drug. And the way it's going to be distributed is you'll have someone like places like in Boston, like the Beth Israel or the Brigham or the Mass General, will have the drug. It won't be present at every hospital, unfortunately. And there'll be a doctor who's very knowledgeable about this in charge, called a steward. And basically, when people have bleeding in the brain or a major bleed, usually in the GI tract, they will ask him or her whether they can get this drug, and he or she is probably going to want to know what else they've tried to do, whether they've given them blood, whether they've given them volume, whether they've given them pressure, other clotting factors, etc. And then, if it looks like it's a life-threatening situation, they'll probably release the drug. So I'm going to stop there. And basically open up the floor for any questions about this presentation.
Great. Thank you so much, Dr. Berkman. That was really informative and hopefully kind of gave people a better sense of the landscape in terms of reversal, and that really, it's more of, even though it is a real possibility, it's more of a perceived in terms of the likelihood of it happening. So we did get a bunch of questions in. So if you are ready, we will get started.
Let's go.
All right. So do you have any tips on dealing with bleeding, including swollen and sore gums while on blood thinners? They're already using a soft toothbrush, flossing, and rinsing with salt water.
I think those are all excellent suggestions. And, I would talk to your dentist about it. And dentists know a lot about this, and so do oral surgeons, because they pull teeth. And by the way, if you need a tooth extracted, you want to go to an oral surgeon who has some degree of comfort in doing this on anticoagulation, because a lot of dental extractions can be done on full anticoagulation, and they don't need to stop it. And some dentists are some oral surgeons are very squeamish, others are very comfortable. There's been a little bit of discomfort by some of them because there were no reversal agents, probably unnecessarily so, but now that there are, but I don't think most dental bleeds are going to come to getting the reversal agent anyway. But I would say the things you mentioned, talk to your dentist, talk to your they will have a lot of good tips for you.
Mm-hmm. And that kind of is a good introduction to another question we got, which is concerns about being on an anticoagulant and bleeding during a surgery, and what should people know before they undergo a surgery or major dental work when they're on an anticoagulant.
Okay, so let's talk about surgery and dental work, because dental work, for example, if you're going to have a single tooth extracted, you can have that done most of the time on full anticoagulation. But if you're going to have an implant or something like that, or multiple teeth pulled, then you probably should stop the anticoagulation before that. So, an implant or multiple dental extractions would be different than a single dental extraction. For a teeth cleaning and a scaling, you don't need to stop your anticoagulation for that. Now, for surgery, it depends on the surgery. In other words, if you're going to have a skin biopsy or you're going to have cataract surgery, you don't need to stop anticoagulation at all. If you're going to have an endoscopy and they're just going to look in there and they're not going to do a biopsy, you don't need to stop anticoagulation at all. So, there's a lot of things. Pacemaker implantations do not need to stop anticoagulation at all. Intraventricular devices don't need to stop anticoagulation at all. But if you're going to have abdominal surgery or hip surgery or knee surgery, cardiac surgery, well, you've got to stop the anticoagulation prior to that. And depending on the drug you're on, you have to stop it. One of the nice things about the new oral anticoagulants is that they have very short half-lives, like about 9 hours. So usually when I stop the drug a day or so before major surgery, maybe sometimes 2 days. But with Coumadin, you've got to stop it about 4 or 5 days. By the way, if any surgeon tells you you've got to stop these drugs 9 days before surgery, they're confused with Plavix, okay? Plavix is not an anticoagulant. It's an antiplatelet drug, and it does take about 7 or 8 days to get out of the system, but no anticoagulant requires 9 days. So if anyone tells you that, they're misinformed. These new drugs like Eliquis and Xarelto, 2 days max, unless you have really abnormal kidney function. And Coumadin, 4 or 5 days.
Okay, great. So it really is something, though, that you need to ask about and plan for in certain cases.
Yeah, but I would tell you that anyone tells you 9 days,
yeah,
and it's not Plavix, then they're mistaken.
Good to know. So in terms, I know at the end you touched on the availability of reversal agents, particularly the new ones. There was a couple questions on, how many ERs is it really going to be in, and is it going to be easy to have access to? Do you have any kind of sense?
Great question. I think that basically they're going to have more production of it starting next year, but I think it's in about 50 hospitals in the United States. It's not in that many, but if you're in Boston, it's going to be in the main hospitals. I'm sure it's in the Brigham and Women's. I'm sure it's in the Mass General. I'm sure it's in the Beth Israel. Whether it's in the Newton Wellesley or Concord Hospital or something like that, I don't know about that. Lemuel Shattuck, I don't know about hospitals like that. I would be a little skeptical that it's be available there. And then you're just going to have to, if you don't get transferred, you're going to have to take the 4-factor PCC, which is, like a blunt instrument. You're just kind of overcoming bleeding by just pouring on clotting factor. It's not nearly as scientific, but it's certainly better than nothing, and it's what we've been using up until this May, and people with bleeds on Xarelto and Eliquis.
Mm-hmm. And as a follow-on to that question, somebody is wondering if they could get a prescription for a reversal agent to bring with them when they travel.
Nobody will ever give you that. First of all, the drug will be controlled by a given individual in the hospital. In other words, the doctor in the emergency room is not going to be able to do it without talking to somebody. So at my hospital, for example, the drug is only approved for cerebral bleeds in the brain. So in other words, a person comes into the emergency room with a bleed, they're going to have to call the guy who's in charge, and the guy's got to be available immediately because you can't waste time. But he will approve it or not approve it. Whether you got a prescription or not have nothing to do with it. It's whether this guy approves it. So you'd be wasting your time with a prescription because even if the hospital did have the drug, they're not going to give it because it's some outside doctor's prescription. They're not even going to rely on their own doctors. They're going to rely on the given individual who's going to be the expert in the hospital.
Mm-hmm. Okay. Is over-reversal possible with any of these agents?
That's a very good question. Is over-reversal? I don't think so, because the half-life of andexanet is much shorter than the half-life of apixaban or rivaroxaban. I think there's much more concern about the opposite, is that because, let me show you the slide. Let me go back here. Do you still have the slides in front of you?
Yeah.
Okay, so I move back. So you see this area right here, going up here. You see, in other words, person's gotten the drug, and then they got the infusion, and then the level of the anticoagulant starts going up right here. Now, some people are concerned that if a person's having a really bad bleed, that this is a little soon for the drug to be coming up, but they felt 2 hours was the optimal time to form a thrombosis. But somebody who's got a really bad bleed, the concern is not that they'd be overcorrected, but they would be undercorrected because of the short half-life, and you see how rapidly this thing ascends after 2 hours. If there's still bleeding going on after 2 hours. So I think more people are concerned about the opposite than that.
Okay. So there was a quote on one of your slides that said, INR normalization doesn't correlate with safety. This
let's go to that.
patient was just hoping that you could expand on that.
Okay, so basically the bottom line here is I like talking in pictures. So if you've got a cerebral hemorrhage on Coumadin, it has let me just show you that slide here again. Let's look at that. Okay, so I think this doesn't correlate with safety. I think maybe that's a reversal slide I had. Hold on, let me see. Yeah, Coumadin INR normalization does not correlate with safety. Okay, so let's look at this slide now. Here is, okay. So first of all, Coumadin has a 46% mortality. Has a 46% mortality with cerebral bleeding. Somebody's got to mute their phone. There's got a 46%. I'm sorry, someone's talking.
Oh, I don't hear anything.
You don't? Okay, sorry. Well, no. All right, so it's got a 46% mortality here. And basically, the problem is with that is that, oh, it's me. It's myself. I'm hearing myself. I'm wondering, that's interesting. So it's a 46% mortality. So basically, when you try to reverse a Coumadin-induced hemorrhage with Kcentra, it's like closing a barn door after you let the horse out. That's what I mean, is that once you've had a major bleed on Coumadin in the brain, there is no difference in survival at 24 hours whether you reverse it or you don't reverse it.
Wow.
And also, another important point on this slide here is that 2 out of 3 cerebral hemorrhage with Coumadin occur when the INR is right where it's supposed to be, in the 2 to 3 range. So in other words, that's another one of the reasons to switch from Coumadin, is not only the 50% decrease in bleeding in the brain with the new oral anticoagulants, but that even when you've got it under good control, that the majority of the hemorrhages occur in that range. And those things, and when they occur, there's almost a 50% mortality. So in other words, that's why warfarin has a lot of limitations. It's very good at preventing blood clots, both from atrial fibrillation and embolism and from deep venous thrombosis. But it's got all these limitations with it that I outlined before, but I like repetition. So again, it takes 4 days to work. You have to really watch and keep your green vegetables constant. There's a whole phone book full of drug interactions. It would do well bouncing a scale against the dictionary on drug interactions. It requires monitoring every 3 weeks because the dose that's good for you 1 week may not be good next week due to changes in your diet, due to changes in you're just all kinds of things we can't even measure. And it's also the most frequent medication associated with hospital emergency room admissions. So it's got a lot of baggage it carries with it. And a lot of people, they're used to it. They're used to being on it. They're stable on it. So, each person has to make his own decision about that. It's just that they should be informed. That's all. They should just be informed that this drug has a 50% increased risk of bleeding in the brain than the new drugs. And that 2 out of 3 of these bleeds occur when they are in the range where they're supposed to be. And that once you have a bleed in the brain, that reversing it is like closing the barn door after you let the horse out. So that's what I mean by that.
Yeah. Okay. Is K-Centra the same as vitamin K?
No, K-Centra is 4-factor BCC. K-Centra, I'll show you K-Centra here. K-Centra is factor 2, factor 7, factor 9, and factor 10. Here it is right here. 4 factors. K-Centra is a combination of factor 2, factor 7, factor 9, and factor 10.
Okay.
Okay.
Oh no, go ahead.
No, there's no potassium.
Okay. Do I really need to give up activities like skiing if I'm on a blood thinner, especially with the new reversal agents?
These are great questions. So I got guys, frankly, I got players who play basketball, and I tell them, well, why don't you just play outside and don't drive? They say, that's what I am. That's who I am. I drive to the basket, and they get into all this traffic, and they get elbows and stuff. So, I think you've got to, as a doctor, what I have to do is explain to someone what's in their best interest. You don't want to get an elbow in the head. You really want to avoid hitting your head, basically, and not only from things like skiing or basketball, but you want to avoid standing on chairs that are poorly balanced to obtain objects from overhead compartments. You want to hold on to the banister when you go down the stairs. You don't want to wear ill-fitting slippers if you're on anticoagulants, because the last thing you want to do is fall and hit your head. So if you're going to ski, I think that you want to ski very carefully. You want to have a helmet. And, unfortunately, you can't control for some of the wild people out on the ski slopes, particularly on those snowboards that just, are very reckless. That's the problem. I'm sure that, if it was left to yourself, that you'd be probably okay. But I think that you're probably okay. Now, I've had people come in and say to me, I take this anticoagulant, and I only ski once every 2 to 3 weeks. Can I go off of the anticoagulant for 1 day? And, if they've got, First of all, I think that, these drugs have very short half-lives, and missing drugs can be devastating. I mean, so I really have cautioned them against that. But I know of people who just skip their drug the day they ski, and I'm not advocating that at all. But I know people do it, and people have asked me about that, and I don't. I just think it's, the downside is so much worse than the upside. But, depends on what skiing means to you. But I think what I would do is, if you're going to ski, I would take your drug and try to ski at a time when it's less busy and there's less people who are really reckless, and not try to ski too fast or be a hot dog, and just try to be moderate.
Great advice. So if we have a few minutes, and we have some questions that came in that aren't on bleeding, but are about anticoagulants, would you be able to answer those as well?
I can try.
Okay. So wondering if these new anticoagulants have shown to have any effect on joints. I'm assuming joint
Well,
pain.
certainly if you bleed into a joint, it's going to have an effect in your joints. I mean, you can bleed any place. In these trials, the majority of bleeds have been in the brain and in the GI tract, not in the joints. But any anticoagulant, you could bleed into your joints. But there's no special propensity for these drugs, particularly to bleed in the joints.
Mm-hmm. Okay. Um, this patient has had a second DVT. They've been on a DOAC for 3 months. The acute clot is gone, but my leg doesn't feel better yet. Is that to be expected?
It's common, and if it's still swollen, they may have what's called post-thrombotic syndrome. And, I mean, what they need to do is to get that leg scanned to just see what the status is of that clot, whether it's subacute or whether it's chronic or whether it's recanalized. And also they'll be able to look to see if there's reflux of the valves, to see if there's been damage to the valves. But unfortunately, 25-30% of people that get blood clots above the knee are going to have chronic sequelae, like swelling, etc. So what you want to know is whether the statuses of that clot and what the statuses of the valves. And you might want to wear compression hose. It doesn't prevent this, but it can make you more comfortable with it, and also elevate the leg as much as possible when you're not standing. And I think that things like that would help. But I think you should talk to your doctor about that. Particularly if the second clot is in the same leg as the first clot, there is an increased risk of getting swelling in the legs if both clots have been in the same leg.
Mm-hmm. And on our website, on the NATF website, under support groups, we have the recordings of all the past support groups, and we do have one or two on post-thrombotic syndrome. So if you're just looking for a little more information on that, those are really great resources. What is the effect of the anticoagulants on the kidneys?
Well, it's not that they have an effect on the kidneys, it's that the kidneys have an effect on them. In other words, the different anticoagulants are excreted by the kidneys, whereas Coumadin isn't. Coumadin is metabolized in the liver. So if you have kidney disease, like a drug like Pradaxa is 80% excreted by the kidney, you have to use a lower dose. And with most of these drugs, if you get your kidney function a little worse, they drop the dose of the drugs. For example, in atrial fibrillation with Xarelto, the dose is 20 milligrams with a creatinine clearance over 50, which is moderate renal disease. But under 50, the dose is 15. And with Eliquis, if your creatinine clearance is below, I believe it's 30, and you're over 80, and you're under 60 kilograms, then you use a lower dose. But basically, an atrial fibrillation. There's no major changes particularly. And also in deep venous thrombosis with Xarelto under 30 cc's, it's advised not to use it because it builds up. It's not the kidney. It's not that it damages the kidney. It's the kidney can't excrete it very well if it's not functioning very well. So the level of the drug builds up and can increase the risk of bleeding.
Mm-hmm. Interesting. Okay. Would you be able to, there's a lot of interest in the study that shows the cerebral bleeds when the INR is between 2 and 3. Would you be able to email me that citation, Dr. Berkman, and I could send it out to the group?
Well, I can show it to you right here. It's right on the slide. Hold on.
Perfect.
Here it is. It's Heileck Singer, Annals of Internal Medicine, and I think it's July 3rd, 1994.
Perfect. Thank you. Another one just came in. How much of a risk is it to use an SSRI or SNRI while on the newer anticoagulants?
Well, it is a risk. It's like whenever you add both one of these drugs to an antiplatelet drug, there's increased risk. Like you're doubling the risk of bleeding when you add it to an NSAID, and you increase the risk even more when you add it to aspirin. And an SSRI does affect the platelets, so there is an increase. Now, it's not as much with aspirin or with NSAIDs, but it does have an increase in risk. So any of these SSRIs will increase the risk.
Mm-hmm. Okay, and one last question. Is there any link between these new anticoagulants and macular degeneration?
Well, that's interesting. Not that I know of, but I have my database right here. So I have not heard that. But just a second. I always can learn something new. So let me see. Hold on. Well, I'm not picking it up so fast. I've not heard that.
Okay, fair enough. Well, thank you so much, Dr. Berkman, for joining us this evening. This was really informative and really helpful. You gave great answers to everyone's questions, and we really appreciate you taking the time.
Oh, you're welcome.
Thank you.
You have a nice evening.
Okay, and so just so everyone knows, our next support group will be on January 7th, and it's with Dr. Ebrahim Barkuda, who is a hospitalist at Brigham and Women's Hospital in Boston, and he's going to be presenting on how to stay safe in the hospital, which is a particularly important topic for patients at risk for or who have had a previous blood clot, as hospital stays are linked to an increase in blood clots. So we hope you'll join us for that. We also have our blood clot support group planned out through the end of July 2019, which is hard to believe. So that's all on the NATF website under patients and then support groups. All the dates and speakers and topics are listed there. So thank you again, Dr. Barkuda, and Dr. Berkman, and thank you to everyone for joining us this evening. And we hope that you have a happy and healthy holiday season, and we look forward to speaking with you in 2019.
Oh, I'm just looking up here. I'm just looking up here about what did you say? Macular degeneration?
Yes.
I don't see any. I don't see it as a side effect.
Okay.
No. I mean, maybe it's been reported once, but it's not considered a significant side effect.
Good to know. Well, one less thing to worry about.
Okay.
All right. Thanks so much, Dr. Berkman.
Okay. Take care.
Yep. See you in a few weeks. Bye-bye.
Bye.